This is Josh Young, live from Amsterdam for iWorld Meeting Reporter. Today is October 5th, 2013. I'm interviewing speakers from the 31st Congress of the European Society of Cataract and Refractive Surgeons in Amsterdam. I'm asking them detailed questions about the things that I, as an ophthalmologist, want to know. I'm here with Doug Koch, who is giving the Binkhorst lecture, the 2013 ESCRS Binkhorst lecture. Just a wonderful, wonderful talk. Let me ask you this: in the Stone Age for us, by which I mean the mid-1990s, corneal optics meant the topography of the corneal surface, and that was it. You describe a much more nuanced understanding of the optics of the cornea. Can I get you to flesh that out for me?
We are becoming so much more sophisticated in understanding how to measure the cornea, what we're doing to the cornea, and how this affects a whole spectrum of things in terms of patients' vision. In addition to what you said, basically in the 1990s, we almost only had just keratometry. We had a little topography. Now we're doing things like measuring epithelial thickness and how it changes with our procedures. We're looking at the posterior cornea and how it changes with our procedures. We're looking at things like the size of the optical zone to understand quality of vision. And then we're trying to put all of this together in selecting IOLs for our patients. It's become much more interesting, but of course, more complex.
Doug, how does the ablated cornea influence our IOL calculations beyond things like just the fact that we can't use keratometry because the central cornea is flatter than for post-myopic treatments, flatter than the part of the cornea that's being measured by K. There's much more going on than just the topography.
Josh, that's really such a key question because it affects all of us in practice who are seeing these patients every day. And the implications are several. There's the whole issue of how do we manage the spherical aberration that may have changed from the refractive surgical procedure and matching the IOL to that. Are they a candidate now for a multifocal IOL if they've had higher aorta aberrations induced by their procedure? How do you calculate intraocular lens power? What do you do with that now that we know that we changed the ratio between the front and the back? And the last topic is what do we do about posterior corneal astigmatism? Because in our work has shown you can estimate posterior corneal astigmatism when you know anterior corneal astigmatism. Well, guess what? We just got rid of the patient's or changed the patient's anterior corneal astigmatism, so that no longer gives us a clue.
Doug, I'm so happy that you're here with me today, and I'll tell you why. The meeting here is wonderful. I'm learning a ton of stuff. I'm going to be back in the trenches Thursday. I'm going to have a patient come in who is going to be there for measurements in advance of cataract surgery, post LASIK. I would not know what to do. Now I know exactly what I'm going to do. I'm going to do whatever it is that you do. What do you do when that patient comes in?
Well, I spend an inordinate amount of time measuring them. I measure the front. I try to measure the back. I use the complex series of formulas that are calculated on the ESCRS website that are on the IOL calculator there. We use OCT to try to measure corneal power. We use intraoperative aberrometry. So, for the man or woman in practice who's really looking at what to do, it's a challenge. Do your best with topography. Do your best with your calculations. And just advise your patients that this is a tough world that you're in, and that perfection is not easy and could require additional steps post-operatively.
Doug, great talk on a topic that's really starting to dominate practice. Thank you so much for spending time with us today.